Hi, welcome to the Avaaz Podcast, everybody. I'm Roop, the moderator for the podcast, and this is Dr. Madhu and Dr. Nav joining us for a conversation today about GLP-1s, also known as Ozempic. It's one of the brand names. So everyone has been talking about Ozempic or Wegovy or one of those medicines lately. We hear about it with Hollywood and Bollywood superstars. We look at pictures of people and think, hey, they look really different. What's changed? So, conversations are happening everywhere. Gyms, shopping centers, parties, you name it. So, Dr. Nav, tell us a little bit about what you've heard about GLP-1s.
Yeah, I was going to say, if you haven't heard about them yet, you must be living in the dark ages because it's all over social media. And so specifically, we're talking about GLP-1 inhibitors in this episode. And these are medications like the trade name that you mentioned, Ozempic or Mounjaro, Wegovy, Zepbound. And there's even a new pill version that's going to be coming out soon that's right now called Rybelsus. So you'll be hearing about these names soon if you haven't already.
Obviously, we've heard about them in the context of weight loss, but we can't lose focus of what their primary, why they were created in the first place, and that is to control your sugars. So their primary indication was and is to control diabetes and sugar, but we'll talk about what it's now become.
And what we're going to do is we're going to talk about the good, the bad, the ugly. What are GLP-1s? Who actually needs them? What are the risks? And how does it affect South Asians who are using this medication? So first of all, let's start off with the basics. What is GLP-1?
GLP-1 stands for glucagon-like peptide. And these are hormones that are secreted by our gut when we eat. And they have three primary functions, and one of them is that they increase our insulin sensitivity, so we're able to make use of the glucose that's in our bloodstream when we eat. That's number one. Number two is they slow the stomach emptying, so you feel full for longer. It doesn't immediately empty it. And number three is it signals your brain that you're full.
So GLP-1 receptor agonists were originally developed and are still primarily prescribed to improve your glycemic or your sugar control, basically for type 2 diabetics. And you want to control the sugar levels so that your risks of all the complications associated with diabetes is reduced. So far, they're available in injectable form on the market. And as Dr. Nav said, there are pill forms coming up. And I think I had just seen a recent documentary where they said in the United States, the pill form they're anticipating should be out by the summer. So they come in injectable forms. You give it once a week to yourself. It's subcutaneous, so it's not a deep injection. And it leads to lowering your fasting blood sugar, lowering your sugars after you eat, and better lab values of what we call hemoglobin A1C. So the hemoglobin A1C is like a video of what your sugars have been doing for the last 3 months, and it reduces that value by 1 to 2%. Because the insulin release from these medications is glucose dependent, the risk of your sugars falling too low it reduces that risk. So that's important.
So GLP-1s have been used extensively and for a long period of time for treating diabetes. So why are we talking about using them, or why are people using them for weight loss now?
So interestingly enough, when they were first marketed for use in diabetes, it was found that there was a favorable side effect in that they caused weight loss as well. So then many people started using it off-label. So some practitioners would prescribe it off-label for weight loss, not just for diabetes management, which was fine, I guess, but it wasn't really what the true indication was for, and it wasn't really what the studies had researched as to the reasons for prescribing this medication. So now that we know that it helps in obesity as well, so now we're marketing it specifically and prescribing it specifically for obesity, because obesity itself is a chronic health condition that needs to be treated. So when we talk about obesity, we're not just saying, you're like 5-10 pounds overweight. So Obesity means you have a significant weight, higher weight than what is optimal for your height. And this is measured by an index called the BMI, or body mass index. It's a calculation that's based on both your height and your weight. It's not perfect, right? Because oftentimes muscle will weigh even more than fat. And so you don't know whether that increased weight is due to just fat or muscle. And it doesn't really indicate how healthy you are, but it's a good sort of standard score to compare people against each other. So right now, we're saying that these weight loss drugs are indicated specifically for one of two indications. Number one, if your BMI is at or above 30 is one reason. Or number two, if your BMI is at or above 27, plus you have other comorbidities that predispose you to having other long-term health conditions. So these could include things like diabetes, high blood pressure, sleep apnea, things like that, that in addition to having a higher BMI, make you at higher risk for obesity-related conditions.
Yeah. And the way it works is it basically signals to your brain that you're feeling full. So it reduces your appetite and it decreases that food noise. Like I know for me, it's so bad. I'll want like chocolate ice cream. Like I love chocolate ice cream. And then the food noise is like, I really want chocolate ice cream. So apparently it's supposed to reduce that. So it reduces that food noise or that reward signal, like, oh, I've had a hard day. You know, I want a glass of wine or I want whatever, sweets. So what they found in this, it's not just a matter of losing 5 to 10 pounds. You're losing 15 to 25% of your body weight, depending on where you're started out at and depending on what agent you're using and how you're responding to it. So clinical trials have shown people on Ozempic have lost 15 to 20% of their body weight, and people on Mounjaro 20 to 25% of their body weight. Now, why this is such huge news is and we do have to understand that obesity is a chronic illness. And a lot of people have had to go through bariatric surgery to help with their obesity condition. And this is now letting people maybe redefine this. And it's really, the amount of weight they're losing is really approaching the bariatric surgery territory. So it is very life-changing for people.
So bariatric surgery is a tummy tuck?
No, tummy
Like stomach stapling.
Stomach
Okay.
stapling.
Okay.
Yeah, thank you, Nav. So that is it's huge. It's revolutionary, really.
And so you get the benefits without having to go through the complications of having this very major surgery. Yeah.
Because that does have real complications, and I think most people suffer from those complications.
And
It's hard to.
Dr. Nav, we're going to go back to the BMI numbers that you gave us. So BMI of over 30 is considered obese, and a BMI of over 25. And
Over
this is just for
27,
women.
over
This is just for women,
27.
right?
No,
For men too?
Yes.
Okay. So BMI over 27 is considered overweight.
no. BMI. We're just talking about the indications of when you can use these meds. It's if you have a BMI of 27 or more, plus you have high blood pressure, diabetes, sleep apnea, that is an indication. If you don't have the comorbidities, but you just have a BMI of 30 or over, that alone is an indication.
Okay.
And you were asking about just women. And so again, that's why I'm saying it's not a standardized test. Like BMI can be different for women than for men. It can be different in different ethnicities. Like for example, South Asians get diseases at a lower BMI. So that's why I'm saying it's just a standardized test, but it's not really meant to be exact science.
Okay, so Dr. Madhu, you've already touched on one of the things a good thing that this medication does, which is one, control diabetes, but also reduce the need for bariatric surgery. So what are the other good things that GLP-1s are helpful with?
So just like you said, it does improve diabetes control, which is what the medications were originally designed to do. So it lowers your A1C, which, as Dr. Madhu had mentioned before, is a really good indicator for us to monitor how well our blood sugars are being controlled over the previous 2 or 3 months. So we have seen studies that show again and again that it does lower that A1C level, which means that your sugars are indeed being better controlled. It also increases your insulin sensitivity. Insulin sensitivity, so that what that means is that your body needs less insulin in order to control the glucose that's running through your bloodstream. So you don't need as much, and having insulin resistance, which is the opposite of insulin sensitivity, is one of the hallmarks of having uncontrolled diabetes. So you want to control that, and this is how it does that. And then the third thing is it reduces the after meal spikes in your glucose that diabetics often get, which is far harder to control than the general population who doesn't have diabetes. And so that's another way in which it helps to improve diabetes control.
And because of what Dr. Nav has mentioned with respect to the diabetic control and affecting your sugars in a favorable manner, we also find that it really protects for cardiovascular protection. How does it do this? We're not entirely sure, but definitely affecting our insulin resistance, lowering our sugars, this all plays in together. So GLP-1s have shown to reduce the risk of heart attack, reduce the risk of stroke, and lower death associated with these cardiovascular incidents. So given the fact that South Asians are so prone to metabolic disease, which involves high blood pressure, diabetes, stroke, heart disease, this really matters. It's sort of important because we are, as a culture, at higher risk for insulin resistance. And that does lead to all these problems.
That's pretty fascinating. I think as more and more studies come out, we'll find that maybe it's used differently in different ethnic groups. But for now, this is the latest information that we have, and that's why we're able to bring it to you. And we might be able to retouch on this, in future episodes if information changes.
Yeah, for sure.
So GLP-1s, those are the positives. What are some of the downsides?
There's more positives still. We're not done with the positives.
We have more good news.
We have more good news, exactly. So one important thing that we have kind of touched upon in previous episodes is the concept of visceral fat. So these medications work on reducing that visceral or internal organ fat. So we're not talking about what you see on the outside. It does help with that, of course, but more importantly, it works on the visceral fat, which is the type of fat that is more driving things like insulin resistance or fatty liver or inflammation. So not only do you lose fat, but you get healthier on these medications as a result.
Yeah, because a lot of our population, again, South Asians have fatty liver and skinny fat. We've talked about this on a previous episode with fatty liver. It's very common. They might look skinny, but they have fatty liver. So these medications also help with that.
Sounds a bit like a miracle drug to me.
Wow.
Well,
but now you're going to tell me
right,
exactly. Right? Now we can talk about the downside.
So now we're going to talk about the most common one. Those are the gastrointestinal side effects. So what it does, it can cause nausea. You can feel like you have a bit of acid reflux, burping, constipation, bloating. Some people get diarrhea. I personally have not seen that in my patient population, but that is. Vomiting. And why this happens is because they slow down your gastric paresis. What does that mean? Just the way the wave is moving in your stomach and your gut tract so that everything is slowed down. You're slowing down the emptying. So some patients might feel full after 3 bites, or they'll have a little bit of a meal and then they can just go hours without eating. Other people just feel like the food sits there, and it really varies for different people with different doses. So titrating the dose sometimes helps, like changing it down, but not necessarily. It's very individual dependent.
And I understand that it's similar to the fact that some people have when they're taking metformin, right, which is a medication for diabetes.
It is, but I haven't, and this is my anecdotal just from my patients dealing with it. I've seen more diarrhea from and maybe some bloating with metformin, but this feeling full all of a sudden, I've really only seen it with the GLP-1 inhibitors.
Yeah. And then another sort of downside or potential negative to taking GLP-1s is the fact that you will also lose muscle. So you're not just losing fat because you're taking in less food, you're also losing muscle. And unless you counter this with added protein intake and doing strength and resistance training, you're going to lose lean muscle, and that's dangerous, especially for some of the older patients that are taking it that are not already active and not already taking care of their protein needs. So something to be considering.
And so if you're reducing the amount of food you're taking because you're just not hungry, then is there also a risk that you might be undernourished or not getting enough of your nutrients?
I think there definitely can be. So you really have to, it's balancing it, right? You have to be mindful of when you are hungry, what are you eating? Is it nutritional? What is the value of what you're eating, right? So you do have to look at all that. Absolutely, 100%. Another thing that can happen with the rapid weight loss is that you are at higher risk for gallstones. And so obviously then that can lead to gallbladder attacks, and biliary colic, as we call it, is quite painful, and it obviously can require surgery to deal with it. So that is another risk.
And then finally, one of the more serious but thankfully rare complications is that of a condition called pancreatitis. So the pancreas is an organ in our upper abdomen that makes insulin. And in very rare cases, you can develop an inflammation of the pancreas because the pancreatic enzymes that are released are destroying the pancreas from within. And you may not know you have this until you start to get really severe upper abdominal pain. Sometimes it can kind of go straight through into your back. You can be vomiting. And this is a medical condition that I often see in the ER. People need to be admitted for it, have bowel rest, nothing to eat or drink, just IV fluids for days, and just being closely monitored to make sure they don't develop even more severe complications. People can die from it.
Wow. Yeah, it's very serious.
So the complications can be pretty severe then.
Yeah.
Okay. So, when we naturally try to lose weight, you can't tell your body, I want to get a few pounds off my thighs or my tummy or whatever else. So just like that, when you lose weight with Ozempic, you're going to lose weight anywhere, including your face.
And we've all seen the Ozempic face, right? So the rapid weight loss can definitely, as you're aging, you're already sagging or hollowing, which we won't talk about right now.
That's a whole other episode.
That's a whole other episode. Rapid fat loss can lead to loose skin, hollowing, an accelerated almost aging appearance. So that is a negative side effect for sure. You will lose volume in your jawline, your cheeks, your temples. And you're already aging, right? So this is accelerating it. And so a lot of people, and this will then start looking for fillers and Botox and other things to now negate this experience.
So build it back up again. Yeah, I think we've all seen those pictures of celebrities, like where they just have those deep lines here. It's because they've lost so much weight in their faces, and then their cheeks start to like just sag a little bit, and it's a very distinctive look that you'll recognize in when you look at some people's photographs.
Yeah, we won't. You can guess who those celebrities might be. We don't know.
And then one other thing that we should tell you about, and it's a truth that no one really likes to hear, is that there is an end point. You're not going to keep losing weight until you wither away to nothing. You're not going to become suddenly a size 0 from a size 14. There is a plateau. You're going to reach a plateau after which you will not lose any further weight. That's number one. And then number two is if you stop taking the medication, you are going to regain that weight. And the studies, again, show this to be true, that within a year of stopping these medications, you will regain back most of that weight that you've lost. And why is that? It's because, again, you are treating the condition of obesity, which is a chronic health condition, but you're not curing it. So as soon as you take away the medication that's treating it, then it comes back.
And you do have to be mindful and disciplined to do the diet and the exercise. And I'm not saying that will cure a chronic illness like obesity, but it definitely will help with things like insulin resistance, diabetes. So we really do have to. And it's people, including myself, will go, yeah, I'm going to do it. And you'll be good for a few days and you don't exercise. And it's easy not to exercise and you get back into it. So you have to be disciplined. It's very hard. The other thing with these drugs is cost and access. They are expensive. In Canada, they're really not covered for just, they are covered but you have to get special authority, but they can be very costly. I believe Mounjaro can be like $400 per month or so. So that's quite costly for people. And, you want to have access to it. You want to make sure the right people are getting it. People who are not using it off-label just to lose 5 to 10 pounds, using it for cosmetic reasons, but you want to make sure people are using it for true medical reasons.
And so you said it's covered in Canada if you get it prescribed
through special authority in different provincial jurisdictions. It can be, but you really have to fit criteria. It's not just given nilly-willy.
Which is good, right?
It is
you don't
good.
want people misusing it.
Correct.
Okay.
Yeah.
And so are there any specific considerations we need to know about as South Asians and that our listeners need to know about?
I think what we need to talk about here again is that Dr. Nav has mentioned the high visceral fat. We have to talk about we as South Asians have lower muscle mass. We're more insulin resistant at lower BMIs. So someone who might look slim could still be unhealthy inside. We don't know. So these are things that the South Asian community is more specific about.
Yeah. And I would say that, GLP-1s are a powerful tool, but they're part of an overall toolkit. They're not the only thing that's going to help with weight loss. They should be used in the context of everything else that we are always telling people to do, and that is having a good quality diet, making sure you're exercising and doing your strength and resistance training, sleeping well, and managing your stress.
Yeah.
So who are the people that should be taking GLP-1s?
So we're going to summarize it briefly. It really should be evidence-based. So it's not like I have a wedding, I want to lose 10 pounds. No, those are not the people who should be taking it. But if you have type 2 diabetes, if you are obese, if you are fit under the overweight plus the comorbidities of high blood pressure, diabetes, all that kind of stuff. So it is obesity as a medical condition, not for a cosmetic inconvenience, so to speak.
And remember that we did sort of briefly mention Ozempic in the past when we talked about diabetes in a previous episode. And at that time, there actually was a shortage of this medication because so many people were taking it off label for weight loss instead of diabetes. That doesn't seem to be the case anymore because now the supply is starting to keep up with the demand, but we don't know whether that's going to happen again. And if it does, that's going to raise some ethical concerns, right? Like, who should it really be used for? Is diabetes the worst condition, or is obesity the worst condition? And then on top of that, I also wanted to mention that there are so many influencers and social media people out there that are telling people to go on these medications, which is fine. You should still do it in conjunction with your healthcare provider to see if it's right for you. But what you shouldn't do is fall for non-prescription stuff that you find over social media that you don't know what's in them. So always make sure that if you're taking it under the guidance of your healthcare provider.
So the other thing is there are some emerging studies. This is still stuff that's being studied. We don't know enough about it, but we just want to mention it to you. They are looking at the role of GLP-1 inhibitors for fatty liver disease, PCOS, because there's a link with polycystic ovarian syndrome and insulin resistance. So we're looking at that. Sleep apnea, addictions, because again, that your mind gets busy thinking about food. Well, that could apply to nicotine, that could apply to alcohol. Again, this is just being studied. It's not an indication. And there's early data on, they're seeing that people who have used this incidentally, they're seeing less incidences of dementia and Alzheimer's than the people who have used it. So again, we don't know, but it seems like we need to know more. So a lot of studies are being done.
Yeah, which also then brings me to the next point that we don't know the long-term effects. Like, so far, they've only really been out there in mass production and being used by a wide variety of people for about 2 to 5 years. So we don't have long-term data yet. There's still lots that we need to learn about this. And so again, we don't want to be pushing people to start asking their physicians and nurse practitioners for this just yet, unless they think that they need to be on it for the right reasons, because we don't know the long-term effects. And that includes things like effects on bone density, right? Like, so you lose muscle mass, you lose fat mass, then what happens to your bones? Do they become more dense? Does that make you more requiring of doing the resistance training and things like that, or taking more vitamin D and more calcium? We just don't know that yet.
Yeah, so there's lots to say, and we're not going to touch on, there's a whole bunch we've already touched on. We don't need to keep repeating. I know some people mentioning this too, there has been the buzz about, is it related to pancreatic cancer or a thyroid cancer? So far, there is no causal relationship. There was an incidence, I believe, with rodents, where at very high doses, they got thyroid tumors. However, there is still no causal relationship. And again, this is still being studied. So honestly, we have a lot to learn still. There's definitely indications where people should use them. But please, as Dr. Nav mentioned, don't buy it off from somewhere else. Talk to your physician and figure out if you actually truly need it, and then you do need to be monitored regularly.
Absolutely.
It's fascinating because it's such a new topic, and we hear so many things on social media or just through conversations with friends, and it's not factual. So this is factual information. So thank you, doctors. I'm going to ask you for your closing remarks, but I would like to start by saying that it's very exciting. You know, when you have a drug or a medicine that can do so much, then that means the research starts to happen more rapidly as well. And I'm excited to see where this leads us. Final words, Dr. Nav?
I just wanted to say that, I think obesity in the past, we've always thought people can control it. And, if you just ate less or if you just exercise more, you wouldn't be obese. I think what we've learned over time is that obesity is, in fact, a chronic condition similar to high blood pressure or diabetes. And it is exciting. Like you said, it's exciting that we now have a medication that works specifically to aid people in dealing with obesity, not curing it, but treating it.
And I'm really excited because as a member of the South Asian community, I'm really excited to see how this medication will help us in metabolic syndrome to prevent and the deaths and the disease associated with heart attacks and strokes. So I'm excited about that.
Thanks so much for listening to this episode on GLP-1s. We're so glad you were able to join us here on the Avaaz Health Podcast. If you've got ideas or suggestions or have questions, please reach out to us. You can find us on Instagram, Facebook, Twitter, Blue Sky, YouTube. We are everywhere that you are. So reach out and let us know what you think if you have questions for us. And don't forget to follow us and share this episode with your friends. We look forward to bringing you the next episode next time.
The information in this podcast is not a substitute for professional medical advice, diagnosis, or treatment.